Sentinel by Nirav Shah.
Should clarify, it's Alertive, but you did get the other name right. Yeah, so my name is Nirav Shah. I'm a stroke neurologist by training. Thanks for having me. Can you all see my screen?
Yes, we can, and you have 10 minutes.
Perfect, I'll get going. So I'm a stroke neurologist by training. I train in places like Miami, San Francisco, and was stroke director of a healthcare system in Seattle called Swedish, owned by Providence. I left clinical practice a few years ago to start running Alertive full-time, which makes software to monitor and connect patients to providers, remote patient monitoring. And so the big thing that we felt like was missing from connected care was it was very difficult to understand how this data connected to our patients in med management and adherence or titration of therapy. And so our strategy and approach to remote patient monitoring is predicated initially on hypertension and cardiac risks. We now work in kidney care as well as neurology. And the business model is straightforward. It's software as a service, providing recurring reimbursements to practices, health systems, and us for remote patient monitoring. This data gives us a pretty unique advantage in predicting long-term and chronic changes in the patient's health. And then we presented data to American Heart Association around reduction associated with Framingham risk scores in populations in the clinics we serve for over 1,500 patients. We've also presented data later this year that just got accepted around readmission reduction in the context of cardiovascular discharge. And so what we built is a software platform that's turnkey for health systems and provider groups that's really designed to be tailored to their needs around workflows for hypertension, cardiac care, kidney care, or neurology. This helps providers in fee-for-service access new revenue streams, or in value-based care, access specific credits for value-based care and ACOs. And the end goal, of course, is to improve patient outcomes. The real benefit for practice is really advanced integrated proprietary integrations into a suite of devices. So we don't make any of the hardware. We make hardware for software, I should say, that connects into blood pressure cuffs, every vital sign, scales, including new modalities such as ECG, level 4 sleep, CGM, and more. We have devices that are cellular for patients without smartphones. And then our expertise is really around the software revenue cycle management for remote patient monitoring. So if a practice has 20, 30 different plans that they're used to seeing, one of the pain points a lot of us have is, do we know which plan associates with the patient for a specific set of reimbursements? So our software helps the practice, the medical staff, and the MA understand which patient qualifies for remote care. And so, like I said, we have software that connects into third-party hardware for this multimodal platform. And so we don't make the hardware, of course. We make a mobile app and a dashboard that's clinical decision support designed for real-time care. We support every vital sign: blood pressure, pulse ox, weight, glucose, temperature, ECG, activity. We're going to be adding EEG for neural care next year with a device that just got approved. And so our goal is to connect all these different modalities and help decentralize care and take it home. In addition to this year we've just launched Hospital Without Walls telemetry. And so Medicare in late November of 2020 announced Hospital Without Walls reimbursement for DRGs. So now you can admit patients at home. But what was missing is the ability to admit level 3 telemetry patients. So most of us were used to admitting patients to a hospital. We'd want to admit telemetry for things like NSTEMI, TIA, or step down from ICU. And so we built the software to connect real-time blood pressure, equivalent to A-line, as well as ECG in the cloud for this. And so we're starting to work with a number of hospitals in process with some academics to scope and kind of pilot this so that they can deliver real-time home-based monitoring after procedures like cardiac cath, TAVR, or early discharge in settings like heart failure or pneumonia. Our end goal is really to connect acute care to these transitions of care, whether it's post-acute, nursing homes, or transitional care settings, and then back to ambulatory. So we've worked in all parts of the healthcare system. We've presented data to American Heart Association regarding different points of the care continuum, whether it was in ambulatory for long-term chronic hypertension, in discharge, transitions of care, and then from discharge to ambulatory. And so we've demonstrated that our software, when used by providers in the real world, can really make an impact in readmission reduction and long-term outcomes. In addition to all this, in the context of COVID last year and again this year, what we're finding is the need for systems to have decentralized logistics, not only to deploy this technology, but then to retrieve it. And so we built specific software to consent, ship, and refurbish and return. So we have a team that can onboard patients remotely. And so whereas before, if we were in practice, I may use a cardiac monitor and deploy it in my practice, like a Xile patch. Now we don't have that ability because many patients aren't coming back to the building. And even though they may now, maybe with COVID Delta, they won't again. And so we built software, basically virtualize the onboarding process specifically for patients in our demographic. 80% of our patients that we monitor today are over 70. Here's a little bit of how it works. We work with practices and systems of care to onboard the practice, help them understand which patients qualify on the basis of diagnoses like hypertension, CAD, CHF, and then we provide the enrollment software. Either their staff or our team can collaborate in that enrollment. And then we provide the monitoring and communication infrastructure. The reason why we're called Alertive is we help provide this alerting in real time. And so that's where the name comes from. And so we help the providers on the ground have real-time telemetry in a way that they're used to from the hospital setting. So someone has high blood pressure in the face of treatment, they're aware. If it's someone's got fasting hypoglycemia, we can relay that to them quickly as well. And at the end of the month, our software is billing native. So it's designed to work with specific reimbursements, remote patient monitoring reimbursements that Medicare approved a couple of years ago, which is why we left practice to start building this infrastructure. And so here's really the goal, right? If you have a patient like Peter who's coming into the clinic with high blood pressures, and we've all seen this patient, despite being treated after acute coronary syndrome, our goal is to make sure Peter gets to normal. But the challenge for all of us has been without real-time data when that patient's at home, we don't know what his blood pressure is. So our software has been able to do that, not only at the individual level, but in aggregate as well. And so the data I alluded to earlier that we presented last year at American Heart was across 1,544 patients in resistant refractory patients, average age of 72, that had a significant 9.2 millimeter reduction, representing this 15% Framingham score reduction in patients with cardiac risk. And so these are in real clinics across many states like Tennessee and Phoenix and Florida. In addition to this, we help these practices generate revenue. And so an average clinic can achieve really high and meaningful reimbursement rates through the billing software that we provide for these reimbursements. And in fact, this is just the beginning. Medicare just announced a new set of codes that are likely to be approved, remote therapeutic monitoring. And so I think for us and the world of healthcare, as it starts to shift home, we have the opportunity to kind of build this infrastructure, help take it home, and really be part of this care journey so that when patients show up to the building, they have all the tools and data that they need so that we can provide better care. So if you can imagine a patient who's got high blood pressure or chest pain or palpitations, maybe they get remote patient monitoring, they'll get a video visit, labs and medications will be shipped home so they can get those. They might provide some text-based chat and check-in. So when they show up and they see the clinician, it can be a much higher quality visit because we actually have the data in front of us. What I was used to doing just a few years ago was, every time someone came with a numb toe, I'd test for everything from multiple sclerosis to diabetes because I didn't have enough data to make the right decision. So I'd do MRIs and A1Cs, and in general terms, I only had to do that because it was the only way I could take care of this patient. And it was hard to get all that data in piecemeal. So I did it all at once. And so that's a little bit about Alertive. I'll turn it over and answer any questions about the business or the next steps. What we're looking for is introductions to health systems, as well as practices that are, generally speaking, primary care, nephrology, neurology, and cardiology.
Judges, any questions?
I'm curious, how do you envision for your system to fit in the current situation when doctors already have multiple other systems and softwares? And how do you prevent them from being in a situation where they are dealing with alarm fatigue? So they are only notified when it's something important.
Okay, the software is designed to notify people only when there's a clinical risk, and it's not for the provider generally, it's for their staff. And so the providers and the staff pick the protocols. So if they care about fasting hypoglycemia at certain hours, they'll be notified about those. As far as how does it work with other software tools that system use, we integrate with various EHRs. So we're already in 40 healthcare systems and practices integrated with multiple major EMRs right now.
What are those major EMRs?
Epic, Cerner, Allscripts.
Did I just hear correctly that you said that you already work with 40 practices?
Mm-hmm, that's right. That's right. Sorry, can you hear me?
Yeah. Touching on Martina's question,
I can't tell if it's me, but can you guys hear me clearly?
I think we lost the audio there.
For me?
No.
Oh,
From our judge.
okay.
Any other
Hello?
questions? Yeah,
Can
I
you hear
think,
me?
yeah, now we can hear you.
Okay. I was going to ask Nirav, there are many startups and many companies that rely on not only the device, but that SaaS model as well as a part of their business model, right?
Mhm.
So they depend on that. So therefore, how are you going to compete with folks who already have built-in SaaS for remote patient monitoring? Yeah, we always hear startups. I have this device and which can be used at home, and we can connect to the doctor because we have a SaaS model as well. So how are you going to compete with them?
I mean, it's how we've been competing with it to date, right? So we're growing pretty quickly. We've grown 300% year over year, and so we tend to win across a few different dimensions, right? One's is clinical credibility. I think the other judge, who we can't hear currently, was talking about the billing. That's really meaningful, right? So we go at risk in some cases to ensure that we help the practice generate the billing. So it's not just flat, based on revenue. In addition to that, it's this clinical credibility, right? So that our team's providing workflows that are deep and meaningful relative to guidelines. So we work with health systems like Bay State and Springfield, Mass, specifically around automating blood pressure control in a centralized protocol that they've developed. And so their pharmacists can treat hundreds of patients to a protocol. And so that's really how we've been able to advance our approach and serve many different stakeholders within the health system. And then lastly, it's around the modalities. So to our knowledge, no one else has tied the more modern modalities together. So you're certainly right that there are companies that have made their own unique technology and they're trying to sell it as a point solution. In general terms, we're a platform, right? So we work through the software, whether it's revenue cycle management or the electronic record, to help connect these different devices. And so we're not in general in conflict with most devices. And so that's the other way we help. We serve as a channel for devices. And so, for example, a new company just got FDA approval for EEG. I care a lot about EEG care because it's very underserved. And so to the extent that we serve more neurologists or people with spells in primary care, we'll deploy EEG-based technology in 2022. Does that make sense?
Thank you. Any more questions from the judges?
I'm curious.
I had a, oh, sorry.
Go ahead. Go ahead. I want to give you space.
So just very quickly, I think I might have missed this, but do you have your own set of clinicians and other people working behind the scenes with the patients, or is it you're only leveraging patients' existing clinical teams?
Yeah, we do. We have about 70 people on the team. We have our own fractionalized care team. So we have nurses and MAs that work part-time and cardiac techs effectively for the telemetry we just launched. And so if we're providing real-time cardiac telemetry, we'll eventually be adding more of these cardiac techs. And at some point, as you can imagine, if we're adding neurophysiology for EEG, we'll add neurophys techs as well to look at the data and triage it to an epileptologist for a system of care. And so there's service software and hardware that we're connected with to provide this really decentralized, rich kind of healthcare home experience. So from the provider and systems perspective, it's prescribing remote care, so they get the diagnostics.
Thanks.
Mm-hmm.
Yeah, my question was actually also related to the team. How do you deal with software and hardware? Do you have internal people to help you with these aspects?
Yeah. So we're SOC 2 Type 2 in process. We have a team of 15 engineers currently that have integrated multiple devices. So we've worked with over 12 vendors across all the vital signs I just mentioned earlier. And so all those devices are brought together for the right reporting, and they can be brought together in different workflows. So for example, if you wanted pulse ox and temperature for COVID pneumonia, you'd be able to have both of those together, and it'd be able to be used in a specific workflow dedicated to you.
Yeah, thank you. If I may have a suggestion, if, like having 40 practices that already implemented, 15 engineers, 70 people on the team, it's super valuable. So you may want to consider adding it to your slides.
That's good. Yeah, that's a good point.
Yeah, thank you.
Great. Thank you very much, Nirav.